Alright guys, we're back and we're talking today about propranolol, and we talked about the betalol, and we're going to talk about propranolol and the differences between, and slow and low. That's definitely it for those of you guys that are former music fans. Long and the short is that this guy is a beta blocker, and we use it for abnormal heart rhythms. It's used to slow heart rates and force a contraction. Now, I'm going to stress this. The OLOLs, with this class of beta blocker that we're talking about, so it's a class 2 antiarrhythmic drug, so it can be used for certain tachycardias. Here's the problem with it, though. Again, remember when I said it not only does the heart rate, but force of contraction. And that's where the real rub of using this drug is. And as a matter of fact, it's a lot of times why docs don't want you to use the beta blockers in the emergent setting, because they're really scared, because improperly done, you're going to blow out the blood pressure. And that's one of the biggest problems with using it, and it's why you shouldn't be using it. So again, it's a non-selective, and that's the big thing there. Remember that the ALOLs, very selective. It does primarily just the force of contraction, doesn't really mess with the heart rate, does the vasculature. This guy does everything, all right? And he does force of contraction and the heart rate. And it reduced the good news about that. So if I reduce the workload of the heart, it reduces the myocardial oxygen consumption. So somebody having a heart attack, this is actually, they're tachycardic, they're really hypertensive. Yeah, this is a drug that's going to help protect them, okay? Now, the problem with that is, again, we usually don't do it the right way, and it usually ends up hurting the patient in the emergent setting more than it does help them. Onset of action, usually 15 to 60 minutes, and usually lasts for about 6 to 12 hours, which is, again, I think another one of the reasons the docs are kind of leery about giving us the access to it, especially around this area. But there's other places in the country where this is definitely an expected drug to be given, especially if it meets the certain criteria. Again, it controls recurrent VTAC and recurrent ventricular fibrillation, where lidocaine are secondary to digitalis toxicity. So anytime that we have these problems, the beta blockers probably are our way to go. It helps control the PSVT and, again, prevention of angina and hypertension. I know that with me having 2 stents and being prone to go into VTAC, I'm on a beta blocker, and because I'm on a beta blocker, that's to keep that heart rate down as well as help with the blood pressure. So you will see this being given a lot orally to your patients, not only the propranolol, but metoprolol, sotalol, but it's all the OLOL drugs. All right, so again, this guy, it can definitely cause some hallucinations. It can definitely cause some syncope, big time problems with that. One of the biggest problems with giving a beta blocker is you can actually cause the AV junction to end up in an AV block. It can definitely slow the heart rate to a dangerous level. And again, it can actually give you chest pain a little bit. Congestive heart failure, it can happen if, essentially, remember, you're reducing heart rate and force of contraction, which can help build up a backup, okay? It also has been known to give bronchospasms. Just remember, we talked about that with ALOLs, but it definitely can do it, especially if they're on a beta agonist drug, your albuterols, Zopinex. If they're on those type of drugs, again, it's going to counteract what those drugs do and therefore cause the bronchospasm. Get a little diarrhea, nausea, vomiting. It can happen with that. When not to give this drug, and I want to stress this one. If they've got asthma, COPD, congestive heart failure, we really don't want to be given the beta blockers, especially in an emergent setting. If their blood pressure's low, that's an absolute no-no. If they have depressed cardiac function, if they're really slow in the heart rate, if they've got any 2nd or 3rd degree blocks, any sinus bradycardia, don't give it. Okay, it's extremely dangerous. Okay, so this is the 40-year-old guy that's hypertensive and tachycardic from having a heart attack. Great drug to give. The guy who's got COPD really bad along with CHF and is now currently in the 2nd degree type 2. Stay away from it, okay? A lot of times paramedics, they give it off the recipe, and you guys know my feelings about this. You got to know when to give something and when not to. This is one of those drugs that, being a clinician, you don't just check it off and say, I gave the labetalol. This is one of those drugs in which, clinically has to be appropriate to give. Now, diabetics, the reason that they like to stay away from it in diabetics is because it masks the symptoms of the hypoglycemia. And that's why. So that one's kind of a relative part. Digitalis, use it with digitalis. If they're on digoxin already, these guys, it can cause a very severe bradycardia. Use other antihypertensives, can cause a lot of hypotension. In other words, you give them nitroglycerin. God forbid you give them labetalol and propranolol. Really stupid idea, okay? Really, really, really stupid idea. Your interactions with that, it's used with epinephrine. It can cause severe vasoconstriction. And it will also decrease the heart rate. It should not be given with any calcium channel blockers, guys. Verapamil, cardizem is another one that can worsen the AV conduction. And again, it can actually throw them into a major block. Succinylcholine effects may be enhanced by giving propranolol. But again, if you're going to have to RSI this person, kind of keep that in the back of your mind. Calcium channel blockers, they don't play very nice with these guys. And insulin hypoglycemic effects are usually prolonged because they're on a beta blocker. And I can tell you from personal experience that actually, when I do have a hypoglycemic event, it happens like that. It can be reversed by isoproterenol, norepinephrine, dopamine, or dobutamine. So if you gave them too much, you're probably going to go for that pressor as a drip. The reason that this guy right here is super isoprel, we're going to go over this a little bit later as far as third semester. This guy uses a ton of myocardial oxygen. So there's only very limited places where you should even use this drug. If you stop the propranolol quickly, you're probably going to get some chest pain and probably going to throw some MI. They're going to throw some arrhythmias, or you can actually cause them to have an MI. The propranolol, again, it can mask the symptoms of hypoglycemia. So again, get their blood sugar. Just double check it. And if they're starting to act weird, get their blood sugar. All right. Again, geriatric population, matter of fact, if they got hepatic or renal failure, maybe I would probably consider cutting down the dose if giving it at all. You should have atropine readily available in case they do go into an AV block. It can help, it helps the AV conduction. And again, beta-1 selective drugs are now more commonly used for the cardiac emergencies. And that example would be the labetalol. So again, remember, this is kind of like the labetalol is kind of a sniper effect versus your propranolol, which is more a shotgun explosion type event. Matter of fact, they usually I will tell you that propranolol is kind of the one that they're actually using a little bit more of nowadays is the sotalol, because it has, again, less side effects from that. So how we're going to give propranolol, 1 to 3 milligrams, usually about 1 milligram a minute. Nice and slow. Slow. All right. And we usually always do this, by the way, by a physician's order. This is not one that you're going to just, hey, I've got the order, I'm going to give it. No, this is the one that you're going to definitely call the doc and talk to them before you give it. Because, again, risk outweighs the benefits on this one. All right, so we usually give it IVP or IO, and then for home use, again, it can be given orally. It's kind of rarely done for propranolol. It's more of a metoprolol. That's what they usually give to the people when they're giving them a beta blocker at the house. Again, category C for the pregnancy category, not too bad. And I've seen some people on those for that. All right, so that's the end of propranolol, guys. Again, it's a safe. I wouldn't say a safe drug. I think it has to be used situationally. And your problem situationally with this is it's got to meet some certain criteria. Their blood pressure's got to be up. The heart rate's got to be up. And we can't have any types of heart blocks, whether it be a second or third degree block, left bundle branch blocks, right bundle branch blocks. Those, you really want to stay away from the beta blockers in that case, because it can cause additional problems, especially in a pre-hospital setting. All right, guys, we'll see you on the next one.